So today we are going to discuss is impression making procedure. So first of all you should know impression. What is an impression? Impression is a negative imprint of the oral tissue, including the areas where teeth are present or absent. So these impressions are made are taken using material that hardens or set to form a negative replica of the patient mouth. So this replica is available is then used to create a positive replica in the form of the dies. So this negative replica is then used to create a positive cast or model in the impression which the denture will be constructed. Now what is the importance of this impression? Impression making, we know it's a primary step in complete denture fabrication. The accuracy of impression directly impacts the fit and function of the final denture. So errors during this phase can lead to significant problems that include the discomfort for the patient and potential treatment failure. Now let us classify the impression. Impression can be classified based upon several criteria. According to the theory of impression making, we can classify the impression as mucostatic impression, or they are also known as passive impression. So here there is minimal tissue displacement, and it uses a low viscosity material. Other is mucocompressive. Or the functional impression. It involves the tissue under functional load. It includes the tissue that is under the functional load during utilizing the material that compress the tissue. The third is the selective pressure. So it combines the aspect of mucostatic and mucocompressive approaches to apply varying pressure to the different areas. The myostatic impression theory, it focuses on recording the denture base within the muscle attachment. Or dynamic impression, that uses soft liner to adapt the denture base over the time. According to the technique, we can classify it as open mouth, technique. Impression are taken with the mouth open, which can provide better control over pressure distribution, or it can be closed mouth. So here the impression are made with the mouth closed using occlusal rim for recording. According to the type of tray, we can also classify as stock tray impression, that utilizes pre-manufactured trays, or custom trays impression. In the custom tray impression, It employs trays specially designed and fabricated for the individual patient. According to the purpose, we can classify impression as diagnostic impression, that provides a preliminary view of the oral tissue. We can classify them as primary impression. Primary impression is used to create a preliminary cast and special tray. Other is secondary impression. It is taken with a special tray. Thus, remember the secondary impression is taken with a special tray. To obtain a more secure final model. According to the material used, we can classify it as reversible hydrocolloid impression or the irreversible hydrocolloid impression. Now let us discuss again the theories of the impression. The theories are: number one is the mucostatic theory. It was given by Richardson and it was popularized by Henry Page. Remember that. So it relies on, this technique, it relies on the capturing the tissue without applying additional pressure. So it uses material like agar and low viscosity alginate. So what are the advantages of mucostatic impression? It has a good retention, minimal tissue, there is minimal tissue trauma, and the disadvantages are there is poor stability during the occlusion load. The other is mucocompressive theory. It was given by Carol James. So mucocompressive means that it records the tissue under pressure in order to stimulate the occlusal load. So the mucocompressive material, the mucocompressive theory, it uses materials like impression compound and heavy body elastomers. So it has a enhanced stability due to the tissue compression, and the disadvantages are there as potential for tissue rebound. The next is the selective pressure theory. So who gave the selective pressure theory? It was given by Boucher. So here mucostatic and mucocompressive techniques, they get combined. So it utilizes custom tray with the relief areas for specific tissues. The advantages are it has a better support stability due to the controlled pressure, and the disadvantages are require careful customization and technique. The fourth is the myostatic impression technique. In the myostatic, it was introduced for the PPS, that is biofunctional prosthetic system. It records impression with muscle attachment marked. So it has an accurate recording of border areas, complete. There is the disadvantages are there is complexity in the border molding and potential for material issues. The fourth another is the dynamic impression theory. The dynamic impression theory was given by Chairs. Remember that. It uses soft liners to adapt over time. The advantages are it adjusts to changes in the tissue contour, and disadvantage it requires extended time for final tissue adaptation. Now let us discuss the various techniques of the impression making. The first is the primary impression. It is simple and straightforward method to capture the general shape of the mouth. Other is the definitive impression. Now, what is the difference between the mucostatic and mucocompressive impression? Mucostatic aims to capture the oral tissue without additional pressure, whereas mucocompressive impression involves applying pressure to the tissues to record them under functional condition. So, second question is, why is selective pressure theory considered advantageous? Selective pressure theory combines elements of both mucostatic and mucocompressive approaches, allowing for the controlled pressure application in stress-bearing areas, while providing relief in area prone to the pressure. How does the dynamic impression technique adapt to the changes in the mouth? Well, the dynamic impression technique uses soft liners that adapts over time, accommodating the changes in the tissue contour and ensuring a better fit as the tissue settles. Now let us discuss the landmarks of the maxilla. First of all, there are the limiting structures. The limiting structures are labial frenum, labial vestibule, buccal frenum, buccal vestibule, hemular notch, fovea palatini, and posterior palatal seal. The supporting structures, remember, they are the hard palate, rugae, residual alveolar ridge, and the maxillary tuberosity. The relief areas are the mid-palatal sutures, incisive papilla, torus palatinus. The primary stress-bearing areas, they are the horizontal slopes of the hard palate to median suture, and secondary stress-bearing areas, they are the crest of the residual alveolar ridge, rugae, maxillary tuberosity. These all we will discuss one by one. So the first we are going to discuss is the limiting structures. In the limiting structures, these are the structures which determine and confine the extent of the denture. So here the first structure is the labial frenum. So remember, this one is this structure representing is the labial frenum. Remember, the labial frenum, it is a fibrous band, that is, you can see this like a fibrous band that is covered by mucous membrane, and that extends from the labial aspect of residual ridge to the lip. The most is it has no muscle attachment, so there is no muscle attachment, it lacks muscle fibers, so that is why it is passive frenum. So what is its clinical consideration? During impression making, remember, making a V-shaped notch should be recorded to accommodate the labial frenum. So this V-shaped notch, to accommodate the labial frenum, this notch should be narrow but deep enough to prevent interference with the labial frenum. Now the labial frenum, it runs horizontally and exert a indirect displacing effect on the denture. So the muscle in this region are thin and their influence on denture is minimal. So there is no muscle attachment. The second structure is the labial vestibule. So this structure is the labial vestibule. So the labial vestibule, what is labial vestibule? It is the space that is bounded by teeth, gingiva and alveolar ridge on one side, and other side there are lip, cheeks on other side. So it is divided by labial frenum into left and right compartment, and it is covered by lining mucosa. Remember, the orbicularis oris muscle, the major muscle here is orbicularis oris, that is the main muscle of the lip. It depends on the support from the labial flank of the denture, so its tone is influenced by these factors. So fibers of orbicularis oris run horizontally The third is the buccal frenum. So this one is the frenum, that is buccal frenum. Here you can see is the buccal frenum. Buccal frenum separates the labial and the buccal vestibule and has muscle attachment. So the muscle attachment here are the levator anguli oris, attaches beneath the frenum. The orbicularis oris, it pull the frenum forward, and the buccinator muscle. The buccinator muscle it will pull the frenum backward. So due to the influence of these muscles, the buccal frenum requires a wider and shallower clearance on the buccal flange of the denture. So what is its significance? Due to the frequent activity of the frenum and associated muscle, the border molding thickness of the buccal notch should be thin and about 2 mm. Fourth is the buccal vestibule. It extends from the buccal frenum anteriorly to the hemular notch posteriorly. The buccal vestibule can vary due to the contraction of the buccinator muscle. The denture buccal flange should be adjusted to avoid interference with the coronoid process of the mandible during mouth opening and lateral movements. So structure that influence the buccal vestibule are the buccinator muscle, masseter muscle, and the coronoid process. The next comes the hemular notch. Hemular notch, it's a depression and it is situated between the tuberosity, maxillary tuberosity, and humulus of medial pterygoid plate. So it is a displaceable area. It contains loose areolar tissue and it can be safely displaced to achieve the posterior palatal seal. Remember, the denture border should extend to the hemular notch. If it is placed anteriorly near the maxillary tuberosity, the denture will lack proper retentive properties due to inadequate border seal. So if you overextend the impression distal to the notch, you will see extreme discomfort due to the interference of the ramus of the mandible. Other is the posterior palatal seal. It is also known as postdem. The posterior palatal seal is the soft area at the junction of the hard and the soft palate. So it is defined as it is available at the junction of hard and the soft palate, on which pressure can be applied within the physiological limit that lead to aid in the retention of the denture. So its function is it enhances the retention by maintaining contact with the soft palate and reduces the gag reflex by preventing gaps between the denture and the soft palate. Also, it prevents food accumulation and compensate for the polymerization shrinkage. Other is pterygomaxillary seal. Pterygomaxillary seal, it extends across the hemular notch and 3 to 4 mm anterior lateral to the mucogingival junction. So you have to avoid placing the posterior denture border over the mid palatal raphe, that is the relief area, or the posterior nasal spine. If the palatal torus, if you see a palatal torus over here, it should be removed. If it interfere with the seal, the denture can extend 1 to 2 mm across the fovea palatinae. These are the fovea palatinae. Other is the vibrating line. The vibrating line, it is an imaginary line across the posterior part of the palatal, marking the division between the movable and the immovable tissues of the soft palate. So it can be identified with when the movable tissue moves during the speech. So remember the distal extent of denture, it should terminate 1 to 2 mm posterior to the vibrating line. Now let us discuss the sporting structure. Sporting structures that resist force, strains or pressure brought on them during the function. The first comes the hard palate. The anterior palate, we know it is formed by the palatal shelves of the maxillary bone and horizontal plates of the palatine bone. So it acts as a primary stress bearing area. The anterior palate is the hard palate is act as a primary stress bearing area. The relief should be provided over the mid palatine suture in the submucosa. So the palate can be flat. The flat palate resists vertical displacement. The rounded and U-shaped palate has the best resistance to the vertical and V-shaped forces, or V-shaped palate has got the least prognosis. Next comes the residual alveolar ridge, the portion of alveolar ridge remaining after the tooth extraction, which resorb over time, is the residual alveolar ridge. The residual ridge resorbs rapidly after the tooth extract. When you extract the tooth, the residual ridge, it gets resorbed rapidly, but supports the denture within the with its resilient submucosa. Now the crest of ridge, remember, may act as a secondary stress bearing area, but the posterolateral border portion, it's primary. Other comes the rugae area. The rugae are the mucosal fold in the anterior palatal mucosa. They provide secondary support and aids in the speech. They act as a secondary stress bearing area. So the denture, remember, the denture base should reproduce the contour of the rugae for the comfort. Other is the maxillary tuberosity. Maxillary tuberosity, it is the most distal portion of the alveolar ridge. It is a bulbous extension of residual ridge in the molar region that is important for the sport. Remember, the denture base should cover the tuberosity and fill the hemular notch, and providing the stability and resistance to the lateral forces. Now, why is the posterior palatal seal important in the denture design? We know posterior palatal seal, its aid in retention, food accumulation and compensation for the polymerization shrinkage. So there is a tight fit between the denture and the soft palate, so that would enhance the overall stability. How should the buccal frenum should be managed during the denture construction? The buccal frenum should be given wider clearance on the buccal flange of the denture due to influence of the surrounding muscle. so that can displace the frenum and affect the denture fit. So what should be done if a palatal torus interfere with the posterior palatal seal? So remember, if there is a torus over posterior palatal seal that interfere with, it should be removed to ensure effective seal and prevent the discomfort or impact the fit of denture. Now coming to the relief area, these area resolve on the constant load. So denture should be designed such that masticatory load is not concentrated in these areas. So what are the relief area? The first is the incisive papillae. Incisive papillae, it's a midline structure. This one is the incisive papilla. It is a midline structure located behind the central incisors, and it marks the exit point of, remember, nasopalatine nerves and the vessels. The portion of incisive papilla can indicate the extent of the ridge resorption. So it is important to provide relief over the incisive papilla in the denture fabrication. The second is the mid-palatine suture. So this one is the mid-palatine suture. It is a medial suture over area of the hard palate covered by thin layer of the submucosa. So this area is sensitive to pressure due to it has a thin submucosa. So the relief should be provided in this area during the denture fabrication to prevent the discomfort. The third are the fovea palatinae. Fovea palatinae is the small depression on the palate formed by the coalescence of the duct of the several mucous glands. So these are two small indentation found on the distal part of the hard palate. Denture can extend 1 to 2 mm beyond the fovea. That is its clinical significance, that allow for adequate retention as the secretion from the fovea spreads a thin film over the denture that aids in the stability of the denture. Remember, in patients who have a thick ropey saliva, it is advisable to relieve the area around the fovea palatinae. Thick saliva can increase the hydrostatic pressure between the denture and the tissue and displace the denture. Other are the cuspid eminence. Cuspid eminence is a bony elevation on the residual ridge that remains after the extraction of canine tooth. It is situated between the canine and the labial and the first premolar region. So why it is important to relieve the incisive papilla in the denture design? Relief is important over the incisive papilla as it prevents the compression of the nasopalatine nerves and the vessel. So this helps to avoid the tissue necrosis and paresthesia of the anterior palate. What should be done if the patient has thick ropey saliva in the relation to fovea palatinae? The fovea palatinae should be relieved to prevent hydrostatic pressure that can displace the denture. Now let us discuss the various landmarks of the mandible. The limiting structures, they are the labial frenum, labial vestibule, buccal frenum, buccal vestibule, retromolar pad, alveolingual sulcus, and retromylohyoid space. The supporting structures are buccal shelf area, residual alveolar ridge. The relief area, the crest of alveolar ridge, mylohyoid ridge, mental foramen, genial tubercle, torus mandibularis. The primary stress bearing areas are the buccal shelf area, and the secondary stress bearing areas are labial and lingual slope of the residual ridge. So if you get a question, and MCQ in that, what are the limiting structure, what are the supporting structure, what are the relief structure, or what are the stress bearing areas. You should remember all of them. Now let us discuss the labial frenum. Labial frenum, it's a fibrous band that is located in the midline of the mandibular arch, similar to the maxillary labial frenum, but it is more active. So it is influenced by the orbicularis oris muscle and is quite sensitive. So when the mouth is opened wide, this frenum causes the sulcus to narrow. So relief should be provided in the anterior labial region of the denture to accommodate this dynamic structure and prevent the discomfort. The fibers of orbicularis are horizontal. Next structure is the labial vestibule. So this one is the labial vestibule. So the labial vestibule is the space between the residual alveolar ridge and the lips. So this area impact the lip support and the denture design. The next structure is the buccal frenum. It may be single band or often two or more band. It is seen in the area of the buccal vestibule. So the buccal frenum is located in the buccal vestibule and overlies the depressor anguli oris muscle, and it is influenced by fibers of the buccinator muscle. So relief is necessary around the buccal frenum to prevent the displacement of the denture during the function. Other is the buccal vestibule. The buccal vestibule extends posteriorly from the buccal frenum to the retromolar pad region. It is influenced by the buccinator muscle. The buccal flange extends up to the external oblique ridge. The denture should cover the buccal shelf area completely. So this area, it is influenced by the masseter muscle. The denture should incorporate a masseteric notch. To accommodate the bulge created by the masseteric contraction. Other is the lingual frenum. The lingual frenum is the fold of tissue under the tongue. Its height and width can vary. High lingual frenum may affect the denture stability. Relief should be provided in the anterior portion of the lingual flank, particularly in the sublingual crescent area. Inadequate clearance may lead to pain and dislodgement of the denture. Other is the alveolingual sulcus. So this area showing is the alveolar lingual sulcus. It extends from the lingual frenum to the retromylohyoid curtain. It is divided into three parts: the anterior region, middle, and posterior region. So the anterior region from the lingual frenum to the premylohyoid fossa, the middle region from the premylohyoid fossa to the distal end of the mylohyoid ridge, and the posterior region, that is also known as, remember, the posterior region is also known as lateral throat form. that is bounded by mylohyoid and other structure. The next area is the retromylohyoid fossa. It is space that is posterior to mylohyoid muscle. It is bounded by the retromylohyoid curtain and superior constrictor of the pharynx. So since it is not activated upon by the mylohyoid in the retromolar fossa, it turns laterally toward the ramus to fill the fossa, and it has a typical S form of the lingual flange. Next is the retromolar pad. Retromolar pad, it is non-keratinized tissue that is located posterior to the third molar. It serves as a posterior seal for mandibular denture, and it is bounded by various muscles and tendons. The denture base should extend only 1/2 to 2/3 over the retromolar pad. That you should remember for your entrance exam. The retromolar papilla should be used as a guide for posterior termination of the denture. Next is the tergomandibular raphe. The tergomandibular raphe, it extends from the hemular process of the medial pterygoid plate to the mylohyoid ridge, and it is attached. It's a site for attachment of superior constrictor and the buccinator muscle. Now let us discuss the supporting structure. In supporting structure, the first is the buccal shelf area. So the primary area of support of the mandibular denture is the buccal shelf area. It is between the mandibular buccal frenum and anterior edge of the masseter muscle, and this area has a thick submucosa and it is perpendicular to the occlusal forces. So that is why it is that makes it a primary stress bearing area. So it is bounded medially by the crest of alveolar ridge, laterally it has external oblique ridge, and distally it has a retromolar pad. So the buccal shelf area provides important support for the denture, especially in the resorbed ridges. Second is the residual alveolar ridge. The residual alveolar ridge is area of the bone that remains after the tooth extraction, and it is therefore considered as a secondary stress bearing area. So the ridge can become flat and concave over time, affecting the fit and the stability of the denture. Proper contouring and adaptation to the ridge are essential to maintain the denture stability and the comfort. So why it is important to relieve the buccal frenum in denture design? Relief is necessary to prevent the denture from being displaced during function due to the attachment of the buccinator and action of the depressor anguli oris muscle. How should the denture be designed to accommodate the retromolar pad? The denture should extend only 1/2 to 2/3 over the retromolar pad to avoid the excessive pressure while ensuring a proper posterior palatal seal. What is the significance of buccal shelf area in the denture design? The buccal shelf area, we know it's a primary stress bearing area due to its thick submucosa and its perpendicular orientation to the occlusal forces that provides its important support for the mandibular denture. Now let us talk about the relief area. In the relief area, the mylohyoid ridge. The mylohyoid ridge, it runs from the along the lingual surface of the mandible and starts near the inferior border of mandible and become flush with the residual alveolar ridge posteriorly. So the area under the mylohyoid ridge can form an undercut, and the thin mucosa over this ridge can be susceptible to trauma from the denture pressure. So relief must be provided over the mylohyoid ridge to avoid discomfort and mucosal irritation. Other is the mental foramen. So this one is the mental foramen. It is located between the first and second premolar region of the mandible. So remember where the location of the mental foramen, it is present between the first and the second premolar region of the mandible. So due to the ridge resorption, the mental foramen may move closely to the ridge, making it vulnerable to the pressure from the denture that can cause paresthesia or discomfort in the denture. So relief must be provided around the mental foramen to prevent the pressure on the nerves. Accurate localization and proper adjustment, they are essential to avoid discomfort and potential nerve damage. Other is the genial tubercle. Genial tubercle are the bony protrusions that are found anteriorly on the lingual side of the mandible. So with the ridge resorption, these tubercle can become more prominent, leading to difficulty in the denture displacement and function. So they lie away from the crest of ridge. Due to resorption, they become prominent, and hence relief is important to avoid any complications. So relief is necessary over the genial tubercle. Ensure the denture does not exert any excess pressure on these areas. In case of severe prominence, additional adjustment or surgical intervention can be done. Other is the torus mandibularis. It is a abnormal bony prominence that is found bilateral on the lingual side of the mandible near the premolar region. So relief must be provided over the torus mandibularis to prevent discomfort and mucosal irritation. Now, how can we accurately locate the mental foramen? The mental foramen, it is typically found between the first and second premolar region. Proper clinical examination and radiographic imaging can help you to accurately locate the foramen. What steps should be taken if the genial tubercle are extremely prominent? The relief should be provided over the genial tubercle. If they are excessively prominent and cause significant discomfort, further intervention or surgical intervention may be done in order to improve the denture fit and the function. How should a torus mandibularis be managed in the denture design? The relief should be incorporated in the denture design over the torus mandibularis. If the torus is large and it causes significant issues, surgical removal may be considered in that cases.